My patient is 60-year lady, married, a homemaker, a Hindu by religion, and a resident of Sasaram, Bihar. She presented with chief complaints of pain abdomen for 1 month, distension of abdomen for 2 weeks, and vomiting since last 3 days. On elaborating history of presenting illness, my patient was apparently well 1 month back when she experienced pain in her lower abdomen, mainly on the left side, which was insidious in onset, vague dull acne in character, intermittent, non-radiating, mild to moderate in intensity, relief on taking oral medications without any known aggravating factors. The patient also noticed distension of her abdomen since last 2 weeks, mainly in the lower abdomen, which was insidious in onset and gradually progressed to attain the present size. It is not related to any food intake. Patient gives history of vomiting since last 4 days, about 1 to 2 episodes per day, a small in amount, around 50 to 100 ml, clear, non-bilious, not related to any food intake. There is no history of any altered bowel habits, no history of melena or bleeding per rectum, no history of any urinary complaints in the form of increased frequency, sense of incomplete evacuation, no history of bleeding for vaginum or vaginal discharge, no history of fever, night sweats, weight loss or loss of appetite, no history of cough, chest pain or hemoptysis, no history of any awareness of lump anywhere in the body, and no history of bony pain. Moving on to past history, there is no history of tuberculosis, diabetes, mellitus, hypertension, or any known comorbidity. There is no history of previous surgery or any known allergy. No history of tubal ligation. Personal history: she consumes vegetarian diet, her sleep and appetite is normal. Her bladder and bowel habits are normal. No history of alcohol or tobacco usage in any form. Menstrual and obstetric history: she postmenopausal lady. She had her menarche at the age of 12 years and attained menopause at 50 years of age. She is married at 22 years and she is parallel living to abortion 0, and all of them were normal vaginal delivery. First child was born at age of 23 years. History of breastfeeding present for 2 months, for 12 months for each child. No history of treatment for infertility. No history of oral contraceptive uses or hormone replacement therapy. Family history: no history of any cancer or cancer-related death in any male or female relatives in the family, as the patient remembers of. So to summarize my history, she is a 60-year postmenopausal lady, prior to living with no known comorbidity, presented with 1 month history of vague, dull acne, intermittent pain, mainly in the lower abdomen, associated with gradually progressive abdominal distension for 2 weeks, and recent onset vomiting since last 4 days, which was clear, non-bilious, and not related to food.
Okay. It's a good history. You've incorporated all the points which we had discussed last time. Good thing is, when you present, I don't say my patient presented with a history. Just the patient or she presented with the history. Okay.
Yes.
And when you talk about family history, no history of any cancer in either male or female relatives. Specifically, you can also mention, you can specifically ask for any breast or ovarian malignancies in any of the female relatives. Okay. This is okay. Your history is good. Okay. Move to your examination.
So I examined my patient after introducing myself and taking her verbal informed consent in well-lit room after adequate exposure after emptying the bladder in presence of female attendant. She is conscious, cooperative, well-oriented to person, place, and time. She is well-built and well-nourished. Her performance status is equal to 1. Weight and height corresponds to BMI of 24.4 kg per meter square. She is off-febrile. Pulse is 64 beats per minute, regular rhythmic and normal in volume. Blood pressure is 112 by 70 millimeter of mercury in right arm supine position. Respiratory rate is 12 per minute. There is no pallor, uterus, edema, cyanosis, or generalized lymphadenopathy. No palpable left ventricular lymphadenopathy. Continuing with systemic examination, there is no focal neurological deficit, and on CNS examination, respiratory system, normal vesicular breath sounds heard, bilateral equal air entry, no added sound, cardiovascular system, S1, S2 heard, no murmurs auscultated, breast and thyroid examinations, no abnormality detected. There was no lump palpable, no algebraic lymph nodes palpable. For abdominal examination on inspection, abdomen is distended. Maybe. Yes, sir.
Go ahead. Interrupting you. Just tell the salient features of your per abdomen examination.
Sorry, sir. Sorry, ma'am.
Just mention the salient features. No need to mention. Abhi, right now for the. Obviously during your exams you will mention everything: inspection, palpation, percussion, auscultation. But as of now, just tell me what the positive findings were.
Okay, ma'am.
So that we can move on to the discussion.
Yes, ma'am. On inspection, abdomen is distended mainly in the lower region, and umbilicus is in midline, slightly pushed upward and strip-like. Respiratory contents for moving equally with the respiration. Flanks are full. Hernial orifices are intact, no coughing pulse, and external genitalia was healthy. On palpation, there was no local rise of temperature or tenderness, and the inspective findings were confirmed. There was a 10 by 6 centimeter mass felt in the lower abdomen in the midline, 6 centimeter from the pubic symphysis, occupying left iliac fossa, hypogastrium, and extending into the right iliac fossa. The superior left and right lateral borders were palpable, however, lower extent could not be made out. It had smooth surface, non-tender, firm in consistency. There was restricted side-to-side mobility. Inguinal lymph nodes were not palpable, and there was no other organ measured. On percussion, there was dull nodes over the lump, and shifting dullness was present. However, there was no fluid stream. On auscultations, normal bowel sounds heard. There was no bruise. On genital examination, external genitalia was healthy. For speculum examination was essentially normal, and for vaginal examinations, on bimanual examination, abdominal pelvic mass felt 10 by 6 centimeter in the left fornix mainly, but not in the right fornix. It was firm in consistency with restricted side-to-side mobility, and it was not palatable. Uterus could not be felt separate. For rectal examination was essentially normal, ma'am. I could not find anything.
Okay. So just go back to your per abdomen slides.
Yes.
Yeah. So even in your exam, your examiner will not have time to listen to all these findings. Okay. So you should learn how to tell your findings in a crisp and short manner. When we ask you to just summarize and tell the positive findings, it should be very crisp. There you don't have to say on inspection, on palpation, or on percussion. Okay. So you just say, go to your next slide. Yeah. So how you mention it as is that on per abdomen examination, a 10 by 6 centimeter abdominopelvic mass was felt, which was occupying left iliac fossa, hypogastrium, and right iliac fossa, non-tender, firm in consistency, smooth surface with a restricted side-to-side mobility. There was, next slide. The shifting dullness was present. That's it. So this is how it should be. Okay. So during your exams, if an examiner tells you to please tell only the positive findings, this is all which needs to be mentioned. Okay. So only when you have time, then you go by this inspection, palpation. Most of the times in an MCH or a DNB exam, the examiner will ask you to just mention the positive findings. You should still do all this exercise in case, there is a fussy examiner who wants to go through everything. But otherwise, they will only tell you what are the positive findings. Now come to your pelvic examination again. Next slide. Yeah, so this is something which Shweta and I both had mentioned last time. So in a gynae examination, in a gynae case, please make sure that you mention it as a PVR examination. Okay. So DRE per se, which you do in cases of anal mass or a colorectal mass, all that is not required in gynae. So here in gynecological examination, you say external genitalia is healthy, cervix and vagina is normal. The same abdominopelvic mass is palpated through left fornix, firm in consistency with restricted mobility, and uterus is not felt separately. On either you mention it as PVR or you mention it as PV and PR. So if you're either which ways, you are not supposed to mention anal tone and all that. That is not required. So what we do in a PVR examination is to see whether there is any nodularity in the pouch of Douglas, which will tell us about the regional extent of the tumor, that is, does it have any pelvic deposits? Secondly, whether the rectal mucosa is stretched or involved. Okay, so if the rectal mucosa is stretched or the rectovaginal septum is tethered, it will give us an indication that the rectum is probably involved and the surgery may entail an anterior or a low anterior resection. Okay, and rectal mucosa, whether it's involved or not, whether it is infiltrating or not. Okay, so this is what is required. Perianal skin, anal tone. Okay, this is not required per se. Okay, this is what we had discussed last time. Okay, now summarize your examination findings. So, just the examination findings. So when you are summarizing, you don't have to mention systemic examination was normal. Just come to what your summary of history is okay. In the summary of examination, the patient has a 10 by 6 centimeter abdominopelvic mass, smooth in surface, firm, restricted side to side mobility, bimanually palpable with shifting dullness present. Yeah, this is correct. Okay, so what is your diagnosis?
In order of my preference, I would like to give adnexal mass as the first differential diagnosis.
What type of an adnexal mass are you suspecting in this? Considering that it's a big mass, you are also feeling shifting dullness, so there is probable amount of ascites. So do you think this is a benign mass or a malignant mass?
Mostly malignant mass.
Yeah, so you should mention that this looks like an adnexal mass, most likely Ca ovary. Okay. So differentials again we had discussed last time, so we will not repeat this. Now quickly, how will you proceed ahead in the management of this patient? What all would you advise now?
I would like to investigate that will lead to diagnosis. So I will first do ultrasonography.
Why would you do an ultrasonography in this patient who's a 60-year-old presenting with a 10 centimeter mass with ascites? Would an ultrasound help you in any way?
Yes, ma'am.
Again, we had discussed this last time.
Yes, ma'am. Ultrasonography will help me to know the organ of origin, whether it will help me to take a guided biopsy if it is required. And it will also tell if there is florid parenchymal metastasis or there is any ascites, there is bilaterality, all these things.
Did you attend last time's class?
Yes, ma'am, I attended.
So again, we are coming to the same thing. Please don't make this again and again. So ultrasound will only tell you, okay, it will tell you only the gross features. Neither will it tell you the status of upper abdominal disease, nor will it tell you the status of peritoneal deposits, nor will it tell you the status of lymph nodes. So in this case, a patient who's 60-year-old has a suspicious 10 by 6 centimeter mass, which you are suspecting to be Ca ovary. If there is one modality which you need to advise for this patient, it is a CT scan. Okay. So in this case, you will advise a CT scan of the whole abdomen and pelvis with an IV and oral contrast. Okay. In case there is ascites and you want to rule out any disease in the thorax, then you can also advise a CT thorax along with it. But see, as of now, you need to understand you are appearing for a super specialty exam. Okay. So you have to choose which is the best investigation. And ultrasound will only help you in telling, okay, as a screening method. Say someone who is in the periphery has come across this patient, has advised an ultrasound and referred the patient to you. When you're doing an ultrasound, not only will it not tell you all these things, it will also not circumvent. Say you've done an ultrasound. Does it mean you still not have to, if in this case you do an ultrasound, does it mean there is no requirement of a CT scan?
No, ma'am.
You will still require a CT scan, right? So ultrasound is not helping you. You will still require a CT scan. Whatever things you need to know to judge the operability of the patient, especially the upper abdominal status, the extent of ascites, the extent of peritoneal disease, the extent of lymphadenopathy, the status of the chest. All this, nothing is being explained to you, or the ultrasound is not helping you in any which way. Okay, so if a patient presents in this age group suspected Ca ovary, you will go for a CT scan. Okay, what else besides the CT scan?
CT scan along with blood investigations like tumor, serum tumor markers from CA, CA99 and CA125.
CA125 should be your first response, okay? You're dealing with an ovarian cancer. Okay. So now I'm not going into details because we have discussed this last time. Yeah, okay. So what were the CT findings in this patient?
Yeah, so is still visible, ma'am?
Yeah, it is visible.
So this is contrast axial cut section, contrast enhanced thorax showing pleural diffusion right side. The lung parenchyma is normal. There is a mild to moderate pleural diffusion in the right side with collapse of the underlying lung. There is ascites surrounding the liver. The liver looks normal. Continuing with the CT abdomen, the liver appears normal and there is fluid around the liver. There is no any para-aortic lymph node. The omentum appears standard and these are bowel loops. There is omental nodularity, you can see here. These are omental nodularity. And followed by a mass, which is 10 by 6 centimeter mass in the pelvic region. Bladder and rectum.
Okay. So do you have the CT report with you, or you have just explained the findings?
There is no CT report.
Okay. Yeah, go ahead.
See the biopsy report, ma'am.
Okay. So what was significant in this CT is, if you go back, check it yourself as well, you will realize it. I mean, this is not a radiology class, but you go back and see the CT findings again. There is a significant amount of mesenteric stranding. Just go down. Go down in the abdominal sections, yeah. Yes. So you can see the mesentery here, and there is significant amount of mesenteric stranding here. Okay?
Yes.
These are the important features which we are trying to see in order to decide whether this patient comes up for surgery or not. There is some amount of clumping of bowel loops as well, but what is significant here, which is the clinching, this thing is the mesenteric disease. Okay? Mesenteric and serosal disease. Anyway, so I'm giving you a hint as well. Okay. So how will you manage this patient now, Ved Prakash?
Yes, I'd like to discuss take the patient to discuss in multidisciplinary.
Be a little loud. Can you increase your volume? Yeah. How will you manage this patient now?
Ma'am, I will take the patient to discuss in multidisciplinary team and plan for neoadjuvant chemotherapy, ma'am. But before that, I will do biopsy, ma'am, from the omental.
Okay. So what are your reasons? What are your reasons for taking this?
For taking into multidisciplinary team, ma'am.
What are your reasons? Why do you want to take this patient for neoadjuvant chemotherapy? Why not for upfront surgery? Tell me your reasons.
Yes, because the patient is having high burden of disease, ma'am. There is ascites with omental caking, and the mesentery is stranded, as well as there is pleural effusion. So I would not like to go for upfront surgery.
Okay, so forget about mesenteric stranding, because mesenteric stranding I have told you. Okay, so does the presence of ascites, omental caking, and significant volume of disease preclude a primary cytoreduction? I know you are working at a center where there is a lot of patient load. You forget about that. Let us say you were at a place where you had all the amenities, okay? And there was a patient who had same age group, 60-year-old, ECOG status 1, presence of massive ascites, peritoneal disease, significant amount of omental cake. Mesentery, let us say there was no mesenteric stranding and there was mild pleural effusion. What would you have done in that case? Considering that you have good facility, you have good intra-op care, you have good post-op care. It is a mild pleural effusion.
The mild pleural effusion could be reactive also, ma'am, or we can do cytology confirm that. Pleural cytology.
Okay, and let us say the cytology was not possible because it is only mild. Okay.
Yes, ma'am.
Let us say that the pleural effusion is minimal or mild, and cytology may or may not be positive, may or may not be possible. Or if they are doing it comes out to be negative. If it comes out, let us say it comes out to be negative, what do you do then?
If a complete cytoreduction is possible, then we will be doing upfront surgery. But if it is not possible, then we will.
Yes. So as per all international guidelines, including the European and the NCCN guidelines, if a case of advanced Ca ovary is operable upfront and optimal cytoreduction is possible, the treatment of choice is primary cytoreduction followed by 6 cycles of chemotherapy. If on the other hand, there are some factors which preclude optimal may be considered for neoadjuvant chemotherapy. In any case, all ovarian cancer disease should undergo cytoreduction or surgery first. This dilemma is only in cases of advanced ovarian cancers. So can you tell me what are the absolute indications of NACT? What are the absolute indications that such patients will receive chemotherapy?
If the ECOG performance status is poor, if there is liver parenchymal disease, if there are deposits or nodes in the porta, if there is root of...
Sorry, there are... Go slow. Poor performance status, intraparenchymal mets, third?
Deposits or lymph node at the porta hepatis.
Okay.
There is a deposit in the root of mesentery. There is extensive small bowel serosal deposits or extensive multi-quadrant peritoneal disease.
So, does the presence of multi-quadrant peritoneal disease preclude an optimal cytoreduction?
Ma'am, along with serosal small bowel disease, ma'am.
Okay, so the first is the poor performance status of the patient, number 1. Okay. Number 2 is intraparenchymal liver or intraparenchymal lung mets. Third is extensive disease at porta hepatis. You are not supposed to say porta hepatic nodes. I mean, we can dissect porta hepatis nodes, that is not a problem. But if there is extensive disease at porta hepatis or at the root of mesentery, just the presence of few deposits here and there or lymph nodes here and there does not mean that the disease is not cytoreducible. When there is extensive disease at root of mesentery which leads to shortening, the mesenteric shortening, that is what precludes a optimal cytoreduction. Because when we do cytoreduction, it is very much possible to excise the mesenteric disease as well. Okay. The fourth is if the patient is not optimal. Sorry?
Suprahilar and supradiaphragmatic.
Don't put your foot in your mouth. It is possible to remove cardiophrenic nodes during primary cytoreduction. Just go by your standard this thing, okay? So poor performance status, intraparenchymal liver or lung mets, extensive disease at porta hepatis or root of mesentery, or such extensive peritoneal carcinomatosis or serosal bowel disease which precludes an optimal cytoreduction. You have to mention this word. Where we feel on the basis of preoperative imaging, or sometimes when we are not sure, we do a diagnostic lab along with it. When we do on the basis of pre-op imaging or pre-op evaluation, if we feel that the disease is too extensive and we will not be able to cytoreduce her optimally, this is when we subject the patient to neoadjuvant chemotherapy. Just the presence of gross ascites or the presence of mild pleural effusion should not be a contraindication to primary cytoreduction. Okay, so the indications of NACT are just these: poor performance status, extensive disease at root of porta hepatis, root of mesentery, intraparenchymal mets, extensive disease which precludes an optimal cytoreduction, and maybe large pleural effusion. That's all. Okay.
Yes.
Okay. So let's talk about surgery now, because we've talked about imaging last time. We have told you what all is to be done during what all is to be checked during a CT. So how do you define an optimal cytoreduction? Quickly. What is complete cytoreduction? What is optimal debulking? What is suboptimal debulking?
Complete cytoreduction is when we are leaving no any gross disease. CT0 is complete cytoreduction.
Okay.
Optimal debulking is when.
So there are two criteria. The traditional criteria which have been used in gynae-oncology subgroups are R0, R1 and R2. CC0, CC1, CC2 is something which is defined by Sugar-Baker. So go by what I'm talking to you right now about is R0, R1, R2. Tell me what that is. What is the definition?
R0 means there is no any microscopic or macroscopic disease.
No gross residual disease. Microscopic you cannot say. Yeah, no.
Yes.
What is R1?
R1 is when microscopic disease is present, and R2 is when macroscopic disease.
No. Being used in GOG trial is R0 is no gross residual. R1, which is still an optimal cytoreduction, is any residual disease which is less than 1 centimeter. R2 is when the gross residual disease is more than 1 centimeter. So there is complete cytoreduction, that is no gross residual. R1, which is optimal, the residual disease is less than 1 centimeter, and R2 where it is more than 1 centimeter. Now you come to the Sugar-Baker's this thing. So what is PCI?
PCI is peritoneal cancer index given by Sugar-Baker.
तेज बोलो बेटा.
PCI is peritoneal.
If you don't know, you tell me.
I know, ma'am. So peritoneal carcinomatosis index given by Sugar-Baker. So he has divided the abdominal cavity in 9 regions. 0 is the central, 1 is the right upper abdomen, 2 is epigastrium, 3 is left upper abdomen.
Okay. So basically, there are actually 13 regions. Okay. So that includes center, right upper, epigastrium, right lower, flank, right lower, left lower, pelvic,
And upper
and upper
jejunum, lower
jejunum, middle. Yeah, okay.
lower
So how
jejunum.
do you define the lesion scores?
Yes.
So let
Lesion
us say
score.
there are different size deposits. How do you assign a score to these lesion scores?
Lesion score 0 when we have no any disease present. Lesion score 1 when the size of the lesion is 0.5 centimeter. Lesion score 2 when the size of the lesion is 0.5 centimeter to 5 centimeter.
Very
Lesion
good.
size 3 when the size is more than 5 centimeter.
Or it is a confluent lesion.
Or
Okay. Yeah. So now when you do a cytoreduction and you remove everything, then you achieve something known as CC1, CC0, CC1, 2 and 3. So what are these?
CC0 is when there is no gross residual disease. CC1 when the residual disease is less than 2.5 mm.
Yes.
CC2 when the residual disease is between 2.5 to 5 mm. And CC3 when the residual lesion is like 2.5 mm to 2.5 centimeters.
So CC2 is 2.5 to 2.5 mm to 2.5 centimeters.
Centimeters.
CC3 is more than
More than
2.5
2.5
centimeters.
centimeters. Yes.
Okay. So why is there so much of stress in achieving optimal cytoreduction or cytoreduction to no gross residual? Why? Why do we say that any surgery, there is no benefit of just going in and debulking the tumor,
Because
and it should actually be cytoreduction to no gross residual? Why?
yes,
What is the
because
reason?
it is associated with survival map as early as Griffith et al. Has shown that residual disease of 1 centimeter will decrease the survival map. And also, if CC1 can be achieved, we can give HIPEC therapy also. So these are
Okay, don't jump to HIPEC immediately. So what the examiner wants to know is what is the advantage of doing a cytoreduction. So the advantage of removing all gross residual disease is that once you have removed the entire tumor, okay, you have basically increased the growth fraction and you are making the disease more susceptible to chemotherapy. Okay, so once you remove everything, the disease becomes more susceptible to chemotherapy because there is increase in tumor growth fraction and there is improved tumor perfusion, because once there are big tumor masses, the center of the tumor mass does not receive much vascular supply. Once the vascular supply inside those big masses is less, if you give chemotherapy first, it will not act. So the advantage of removing a cytoreduction, especially a primary cytoreduction, is to increase this growth fraction, improve the perfusion, and obviously to make it more sensitive to chemotherapy. Okay, so you should briefly know what are the important analysis for cytoreduction. There is one very important analysis by Bristow, which said that every 10% increment in optimal cytoreduction increased your median survival rate by 2 months. Okay, so what are the advantages of primary debulking surgery? This is what is the advantage. What is the disadvantage of primary debulking surgery?
the main disadvantage is that there will be more
primary debulking surgery, we have discussed the advantages. Okay, what is the disadvantage of primary debulking surgery?
There is increase in morbidity, ma'am. There is a increase chance of multivisceral resection, and also there is chance that the adjuvant chemotherapy can be delayed because of these complications.
Very good, correct, very good. So there is a chance of morbidity. The primary cytoreduction is associated with almost 30 to 40% rates of grade 3 or grade 4 morbidity. This can lead to delay in the starting of chemotherapy. And thirdly, the optimal cytoreduction rates in many trials across many centers have been shown to be inferior as compared to those after interval debulking, because chemotherapy decreases the tumor burden and potentially increases resectability. So if you see any of those trials which are comparing primary versus interval cytoreduction, the rates of optimal cytoreduction in primary are much lower. Okay. So what is the advantage, now corollary, what is the advantage of giving chemotherapy first?
With chemotherapy first, ma'am, we can decrease the burden of the tumors, and we can uh, increase. There is no survival advantage, but the post-op complications is decreased, ma'am, with neoadjuvant chemotherapy.
So
And
the
also
thing is,
performance status.
yeah. So the advantage of interval of giving chemotherapy first is number one is that it can be started immediately. Okay. If the patient's performance status is poor or borderline, it can be started immediately and it can lead to improvement in the patient's performance score and bring the patient performance level up to the level that he or she can withstand some amount of this thing. Okay, so it can be started immediately. It improves the performance status, and third, it obviously decreases the tumor burden, potentially making the disease more resectable. What is the disadvantage of giving chemotherapy first?
If there is good response, ma'am, we can firstly may leave that disease, ma'am, in the abdomen while we operate. That is the greatest disadvantage, and there is no overall survival benefit with neoadjuvant chemotherapy.
So no, that is not it. Okay. The disadvantage is that it delays the removal of tumor. Once we keep giving chemotherapy, there is a chance of developing chemotherapy resistance. Okay. And after chemotherapy response, there is some amount of desmoplasia which happens, which makes the surgery slightly more difficult. The point which you said later on is the fourth point, that after chemotherapy we don't know where the original disease lied. Okay. As of now, none of the trials have shown that the survival rates after interval debulking surgery are inferior to primary debulking surgery. So you cannot put this as a point, no matter what your surgeons may be telling you in practice. Okay. Theoretically, even practically, none of the trials up till now have shown that the survival rates with interval debulking are inferior to those of primary debulking. So the disadvantage is that A, it delays the removal of tumor. B, with each successive chemotherapy, there is a chance of increasing chemo resistance. And third, with chemotherapy, you develop desmoplasia or fibrotic reaction, which hampers your surgery. Okay, so which makes your surgery slightly difficult. So this is mainly what is the disadvantage, not the survival rate. Okay, so after primary debulking surgery, or rather primary cytoreduction or interval cytoreduction, what are the side effects? What are the complications which you expect in a patient?
Ma'am, the complications can be divided into intra-op complications, early post-op complication, and late post-op complications.
Okay. Yeah.
In intra-op complications, there can be injury to bladder, rectum, or any bowel, bleeding. In the immediate post-op complications, there can be a paralytic ileus and paralytic ileus can be there, lymphocyte formation can be there, there can be delayed wound healing.
Okay. So yeah, you need to divide it properly. Okay. So one, you're right, intraoperative. Intraoperative, there can be injury to the organs, including bladder, rectum, but also ureters, injury to pelvic blood vessels, injury to nerves, especially during lymph node dissections. Post-operatively, you have complications like infections. The infections can be wound infections because it's a big surgery, long hours. There's a big wound running from xiphisternum to the pubis. Secondly, you can have urinary tract infections. Why do you expect UTIs will be more common in cytoreductions as compared to other smaller surgeries?
Because of it could be because of prolonged catheterization also. And
so why do we have to do prolonged catheterization in cases of CRS?
Because of the nerve injury, probable nerve injury, ma'am, during a lymph node dissection.
Why do you expect nerve injury to the bladder? So when we do a total peritonectomy, including a pelvic peritonectomy, we remove the peritoneum overlying the bladder. Okay. So once we remove the peritoneum over the bladder takes some time to regain its normal function, to regain its normal contractility. That is why after bladder peritonectomy, normally we keep the catheter at least for 10 days, 10 to 12 days. Okay. So that increases the chances of urinary tract infections. Third, Deep vein thrombosis.
DVT,
Okay,
deep vein
DVT. Yes.
thrombosis,
Chances of paralytic ileus, nausea, vomiting.
pleural
Okay.
effusion,
So
pneumonia.
what are the, okay, I'll come to lymphadenectomy later, but what are the complications of lymphadenectomy? Because you have described them previously. So just briefly tell me what are the complications of lymphadenectomy?
Yeah, it can be lymphocyte formation, chylous ascites.
बेटे वैसे ही बोलो ना जैसे आपने पहले बोला था इंट्रा-op
Okay.
and post-op.
Yes, ma'am. Intra-op, early post-op and late post-op. Intra-op can be the injury to the nerve and the nearby vessels.
Which nerve and which vessels?
And cisterna chyli, ma'am.
Like pelvic lymph node dissection में तो कम आएगा. Retroperitoneal में maybe if you are going above the renal vessels. Okay.
In pelvic lymph node
चलो.
dissection, the vessels like iliac vessels,
Yeah.
external iliac vessels, internal iliac vessels.
Which are the two? Okay, come on. Which are the two vessels which are most prone to injury during pelvic lymph node dissection, and which are the two nerves which are more prone to injury during pelvic lymph node dissection?
The vessels are external iliac vein, ma'am, and internal iliac artery. And the nerves are
no, these are generally well seen to a trained surgeon. So I'll tell you. So basically, the internal iliac vein is precarious for injury. The reason for that is when you see the pelvic anatomy, the external iliac artery and vein, they are going at a horizontal plane, where the internal iliac artery also goes horizontally. But if you see the internal iliac vein, it dips down inside the pelvis almost vertically at the confluence of obturator nerve. So it goes down vertically, and especially during lymph node dissection, when you are trying to remove the lymph node bracket around the obturator nerve, sometimes this can be injured. The second is accessory. What? Accessory what?
No idea.
Okay, so it is present in 20% individuals.
Accessory obturator.
Yes, correct. So that can be injured. Okay. When you go to retroperitoneal lymph node dissection, there is what vessel can you injure?
Retroperitoneal lymph node dissection, ma'am, we can
most commonly क्या injure होता है?
Lumbar vessels, ma'am, and the
your what else? I think this okay, yeah, lumbar vessels, and there is something which is known after Fallot's vein. There is something known as Fallot's vein. Okay, Fallot's vein arises about 4 centimeter above the bifurcation of the IVC into common iliac vessels. So Fallot's vein is very much prone to injury during retroperitoneal lymph node dissection. The nerves are generally the nerves which are injured are during pelvic lymph node dissection are the genitofemoral and the obturator nerve, and during retroperitoneal lymph nodes you can obviously injure the sympathetic plexus. Okay, that is why in males you do a nerve sparing RPLND to preserve the function of the to prevent retrograde ejaculation. Yeah. So now what else? Do you have any complications related to diaphragmatic stripping and diaphragmatic resection?
Yes, ma'am.
What can happen? Do you routinely put ICDs? After diaphragmatic stripping?
If there is communication, ma'am, if we iatrogenic injury is there to the diaphragm, there is rent. If there is rent, then we will put.
Okay. So in a routine diaphragmatic stripping, you are not putting.
No, ma'am.
Okay, so there is no right or wrong to this answer. There are many of us which do put even after doing a complete stripping, even when there is no rent, because there is a lot of reactionary pleural effusion happening, and most of our patients are in a ECOG 1, ECOG 2 status. They are not doing their chest physiotherapy properly. We do not train them in chest physiotherapy beforehand. Most of them come up for surgery, and post-operatively they are started on incentive spirometry. So you have to tell what is your institution's protocol. At least I am putting ICDs. Reason for that is this only, that most of our patients are not able to do chest physiotherapy well, and we do get a lot of cases of reactionary pleural effusion. But definitely when there is a rent, you have to put. Okay. So the complications can be pleural effusion, sometimes pneumothorax, and also very rarely a subdiaphragmatic abscess. Okay, so now Okay, now let's just briefly discuss some trials. Okay, just briefly, I will not discuss too in detail. So, what are the trials? Can you name some trials which have shown the non-inferiority of NECT interval debulking as compared to primary debulking?
Yes, ma'am. There are some randomized control trials.
Just name them. Just
like
name them first.
EORTC, Vargat et al. Trial, MRC Chorus,
Yes.
and Scorpion trial.
Correct. And which is the one which is ongoing? Trust trial. Okay. Trust
Yes.
trial.
Okay.
So EORTC, which was the Vergot's trial and the Chorus trial, they compared patients who underwent primary debulking versus those who received chemo and then interval debulking. So they found that the survival rates was not very different. It was about 12 months in both arms, and even the overall survival was 30 months in both arms. The complication rate, however, were much lower in women who underwent interval debulking. So these were what? These were what type of trials? What are they called? Correct, non-inferior. Yes, absolutely. So, but these trials were criticized because the operative time, if you read through these trials, the operative time in Vergot's trial was only about 2 to 3 hours. So, in about 2 to 3 hours, you cannot obviously do justice to a cytoreduction. Cytoreduction, so let me come to this. What are the components of a cytoreductive surgery? Say a patient has come to you with an upfront operable disease and you decide to go for a primary debulking. What all do you remove?
We'll be doing a total abdominal hysterectomy plus bilateral salpingo-oophorectomy plus total omentectomy plus bilateral pelvic lymph node dissection plus
that's controversial. We'll come to it. And
plus total peritoneectomy.
So peritoneectomy, whether total or selective, is again controversial. The idea is to remove all the gross residual disease. Okay, all the gross disease. So whether that involves total parietal peritonectomy or it involves a selective parietal peritonectomy, that is generally the surgeon's prerogative. Right now, there is no indication to show that removal of normal peritoneum in an upfront setting helps in increasing the survival. In an interval setting, you don't know. So you don't know where the original disease was. So it is more or less a conjecture. So yes, you remove the uterus, you remove the adnexa, you remove the ovarian mass. If it is involving the rectum, you do an anterior resection, LAR, whatever. If bowel resection is required, you do a bowel resection. You excise the mesenteric disease. If there is limited serosal disease, you excise that. You do a diaphragmatic stripping if that is involved, do a total omentectomy. And if you go too deep into CRS by Sugar Baker, they also advocate the removal of lesser omentum of the falciform ligament, also of the gallbladder in case you're removing the omental bursa. Okay. So all this has to be removed. All the visible disease has to be removed. Okay. So now coming to this thing. So when you're removing all such disease, doing it in 2 hours is simply not possible. That is why these trials were criticized that both Vergot's and Chorus, the operative time was only 2 to 3 hours. So the quality of cytoreduction was less. The survival rates were also very low. Having an overall survival of 30 months is actually low. So that is why, Scorpion trial and Trust trial. Scorpion trial has been published. This was by an Italian group. So they Advanced Ca Ovary and they use preoperative imaging and a laparoscopic predictive criteria to see if they are upfront operable. And if they were upfront operable, then they were basically divided into one group which underwent primary cytoreduction and another group which underwent chemotherapy and cytoreduction. So this Scorpion trial showed improved survival rates. The OS was almost 48 months, but again, it failed to show that primary cytoreduction was superior to interval cytoreduction. They found that the survival rates between both arms were exactly similar, and like was reported in previous trials, the rates of complications, the rates of hospital stay, the rates of wound infection, the time to start adjuvant chemotherapy, all this was much lesser in the interval group. Okay. Now coming to systematic lymphadenectomy, you said that, we should do a BPLND and RPLND. So what is the incidence of lymph node involvement in advanced ovarian cancers? And if we do a lymphadenectomy, what all basins do we remove?
Ma'am, it is about 20 to 30% chance of help.
No. So 20% chance is there in early. Okay. In an advanced ovarian cancer, the chances of lymph node involvement is as high as 50 to 70%. Okay. So when we do it in an advanced ovarian cancer, we remove the pelvic basins and we remove the retroperitoneal lymph node basin up to the renal artery. So I'll start giving you answers, otherwise we'll not finish through, whatever.
Pommel classification is also there, ma'am, for para-aortic lymph node dissection.
Sorry?
Pommel classification for para-aortic lymph node.
Okay. So, what are the boundaries of pelvic lymph node dissection? Quickly.
Superiorly, ma'am, common iliac bifurcation, inferiorly circumflex iliac vein, and
Yes.
And deep is obturator nerve, and laterally it is genitofemoral nerve.
Medially?
And medially internal iliac artery.
Very good, brilliant. Retroperitoneal lymph node dissection?
Usually it is infrahilar, ma'am. We do a Pommel classification A2 retroperitoneal lymph node dissection, which is from infrahilar region to.
We don't use this classification in terms of ovary. You just have to say retroperitoneal goes up to the renal vessels. So renal vessels superiorly, the common iliac inferiorly, and the bilateral ureters on both sides.
Yes.
Yeah. Okay. Because the chances of, earlier there was a dilemma whether the lymph node should be removed up to IMA. But they found that above IMA and between the renal vessels and the IMA, the incidence of lymph node positivity was as high as 16 to 20%. So you were missing those 16 to 20% lymph nodes if you were restricting your lymph node dissection only to the IMA. So now what is the controversy of lymph node dissection in advanced ovarian cancer? In early ovarian cancer, as of now, there is no controversy. You should do. The reason for that is because it will upstage the disease, as the lymph node involvement can be as high as 25%. So for proper staging of the disease, we need to do a systematic lymphadenectomy in early ovarian cancers. And by early, I mean 1 and 2. In advanced ovarian cancer, why has systematic lymphadenectomy, why has it become controversial?
Because in advanced ovarian cancer, we are doing debulking. So we'll debulk the only enlarged palpable lymph nodes. It is not going to affect the survival, rather it is going to increase the morbidity, as evidenced by few randomized controlled trials.
What are these trials?
These are Lion study by Harter et al. And Fanasi et al.
So what is the Lion trial? Can you tell me briefly?
In Lion trial, they randomized patients from after incising the retroperitoneum. They found they inspected and palpated. If there was enlarged node, then they did the lymph node dissection. But if there is no enlarged node, then they.
No. You're getting confused.
Okay.
So there are two randomized trials. The earlier trial, which was by Panici, was 2005. There they did the debulking. Okay. So in the control group, they basically did only debulking, and the other group, they did a systematic lymphadenectomy, and they found an improvement in PFS. But the fallacy of this trial was that they did a debulking in enlarged nodes. Okay. So Lion trial started with patients of advanced ovarian cancers who had normal lymph nodes, meaning that they did not have any, either on preoperative imaging or on intraoperative palpation. So they screened these patients, did a pre-op evaluation. All of them had normal lymph nodes. Only these patients were inducted into the trial. Once intraoperatively, the intraperitoneal compartment was cytoreduced. They opened the retroperitoneum, palpated all the nodes, and if all the lymph nodes were negative, then they randomized the patients to either receive lymphadenectomy or not to receive lymphadenectomy. So they found that in the lymphadenectomy group, in the group where they did lymphadenectomy, they found positive lymph nodes in almost 56% patients. But in spite of finding microscopic disease in these normal lymph nodes, that did not translate into improved survival. The reason for that was that most of these patients received chemotherapy. And the biggest dilemma in ovarian cancer is that does removal of microscopic disease actually impact your survival once we know that the patient is going to receive adjuvant chemotherapy? So like you rightly said, it did not, in spite of finding more number of positive lymph nodes, it did not increase either the PFS or the OS. Rather, doing systematic lymphadenectomy led to all of these complications which we had talked about. Okay. So, right. Now tell me a little bit, what is second look surgery?
Second look surgery means after primary treatment, if
Yeah.
CA125 is raising, but we are not able to find any disease on imaging.
No, no. So this is not second look surgery. Second look surgery was what was done earlier. So in a patient who is completed treatment and is evidently disease free, clinically the patient is disease free, there previously they would do a re-laparotomy and take multiple biopsies to see if there is any microscopic disease left behind or there. So they found that this exercise actually did not help in improving any survival. So it has now been abandoned. So second look surgery was done for clinically disease-free patients wherein they did a laparotomy, took multiple peritoneal biopsies to check if they are harboring any microscopic disease. But they found that this did not actually improve any survival. So you follow this. So after the treatment, after all this surgery and after IV chemotherapy, say if you've done primary cytoreduction, you give 6 cycles. After neoadjuvant, you give 3. Now you're following up the patient. Okay. So let us say at 6 months, CA125 begins to rise. So it is about 40. Okay. What will you do? Patient is clinically asymptomatic. Just on routine follow-up, at 9 months, they found that CA125 was 40. What will you do?
CA125 is 40, ma'am. Then I would first examine the patient, ma'am, if there is any evidence.
Clinically asymptomatic. Yeah, she's clinically asymptomatic. Physical examination is NED. Only on CA125 evaluation, you found that it was 40 at 9 months.
Previous, I will check, sir, if it is increasing from the previous nascent value. The baseline value has, whether it has increased from the baseline value. So baseline value, if it
Let us say it has increased, what will you do?
It is very mild increase, ma'am. So I can ask her to follow up after 1 month.
So is there any evidence for that? You are right. You will just follow up this patient. But is there any evidence to sustain your statement?
I'm not aware.
So, okay. So basically, in patients who are followed up in cases of biochemical relapse. So this is something known as biochemical relapse, wherein the patient is clinically asymptomatic, okay, and only CA125 has risen, okay. So there was a trial known as OVO5 trial, okay. So there they found that, they divided it into 2 groups. One group received immediate chemotherapy on the rising of CA125. The other group, they waited till the patient became symptomatic. Only then they started chemotherapy. Okay, so this group had delayed onset of chemotherapy only when they became symptomatic, whereas the other group started chemotherapy immediately. So they found that there was no difference in the survival rates between these two patients. Rather, the patients who started their chemotherapy early had a poorer quality of life as compared to the second group. So this is known as OVO5 trial, okay? And this is a clinically, it's a very relevant situation and you will be facing it in your clinical practice, okay? So you need to tell the patient this exactly, that, it has not been found that, starting chemotherapy right away will lead to increased survival. Rather, it will lead to poorer quality of life. Okay. So tell me now a bit about intraperitoneal chemo before I come to HIPEC.
Yes, ma'am. There were few studies, ma'am, where intraperitoneal chemotherapy was done, and it was associated
what is the crux or what is the funda behind intraperitoneal chemotherapy? Do you use all chemotherapy drugs as intraperitoneal chemotherapy agents? So what all am I looking for when I'm giving a particular chemotherapeutic drug as intraperitoneal chemotherapy? First, tell me that.
It should be active locally, ma'am, when there is when we have obtained the optimal cytoreduction, then we can use this intraperitoneal normothermic intraperitoneal chemotherapy. This was done by.
That is something else. Don't confuse normothermic and hyperthermic now. I'm only talking about intraperitoneal chemotherapy, which is given through Bard's catheter, by intraperitoneal catheter.
Yes, ma'am. It is believed that it will act locally and it will have less of the systemic side effects.
So basically the chemotherapy drugs which are used for intraperitoneal chemotherapy or also for HIPEC, these drugs are such which have something known as pharmacological advantage. By pharmacological advantage I mean that they have a high intraperitoneal versus intravenous ratio. As a result, their intraperitoneal concentration is much higher than the IV concentration, and they do not cross the barrier because they have a high molecular weight.
Right.
So the chemotherapy agents which are used for IP chemotherapy should have a high molecular weight so that they are not crossing that barrier. They are not causing a lot of systemic cytotoxicity by increased intravascular absorption. Secondly, they should have a pharmacological advantage, which is basically the ratio of their IP concentration versus IV concentration. So the agents which are used are generally cisplatin in ovary. I'm talking only of ovary right now. Cisplatin has traditionally been used, and other newer trials have also used carboplatin as well as what else?
Mitomycin C.
Mitomycin C, not so much in upfront, no. Maybe in platinum resistant recurrence, but no. Upfront it has been cisplatin, carboplatin, or recently paclitaxel. Okay, recently paclitaxel. So what were these IP? So there were three basic trials. There were three major trials, the most important of which was GOG 172 by Armstrong. And where they showed that the use of intraperitoneal chemotherapy versus just use of IV chemotherapy increased both the PFS and OS rate substantially. So much so that the NCI had to issue a regulatory warning in 2006 saying that these patients, all the patients of advanced ovary should be offered IP chemotherapy, or at least should be told about it, because it leads to almost a 20% reduction in death rate. But why did IP chemotherapy not pick up? What were the disadvantages of IP chemo?
There were more catheter related complications, number one. Number two,
what were those catheter related complications?
Infection, ma'am.
Not just infection.
Infection and poor quality of life.
Nahi. So catheter related complications were the obstruction of the catheter, the leakage, retraction and infections, number one. Number two, because we were using cisplatin, there were also certain systemic side effects like myelosuppression and dyselectrolemia with use of IP cisplatin. As a result of this, only 40% of patients who were able to complete the 6 cycles of IP chemotherapy versus more than 90% of patients who could complete all 6 cycles of IV chemotherapy. So, yes, so that was the major disadvantage, that the patients could not complete their 6 cycles because of this. So there is a recent trial, I don't know whether as surgical onco DNBs you should know or not, but definitely if there are some gynae onco people there here in this group, you will be talked about GOG 252. That is basically another trial. It's a recent trial which is comparing intraperitoneal chemotherapy to dose-dense chemotherapy. And it has not shown any benefit of intraperitoneal chemo, but it has been criticized because it has been used along with BEV. So all, if any, there was an advantage of IP chemotherapy that may have been mitigated by the use of BEV in both arms. So I'm not sure again whether surgical onco people will be asked about this or not. Okay, so now come to HIPEC. So what is the advantage of HIPEC over IP chemotherapy, and what is the advantage of hyperthermia?
With the use of hypothermia, there is a synergistic cytotoxic effect. There is better penetration of the chemotherapeutic drugs, and there is more cytotoxicity. There is more RNA, DNA, and protein denaturation because of heat. So we
Yes.
can use that advantage now.
Yeah, there is also formation of heat shock proteins, which basically attracts NK cells, causing increased apoptosis. Okay. The biggest advantage of HIPEC over intraperitoneal chemotherapy is that it is a one-time procedure. Unlike IP chemotherapy, which needs to be given at least 6 times, this is a one-time procedure. Secondly, it is done at the time of surgery. So, when it is done at the time of surgery, the adhesions have not formed. The chemo-resistant clones have not formed. So, when there are no adhesions, when there are no chemo-resistant clones, then the HIPEC one-time procedure is able to, it is more acceptable, and B, it is acting when there are no adhesions. So, there are no pockets which are not receiving chemotherapy, unlike IP chemotherapy. So is there any, okay, just I'll not go into technical details of HIPEC, but what temperature and what drug? Just tell me quickly.
41 to 43 degrees centigrade. Drugs.
42, yes, 42, yeah, okay. And what drug are we using in ovary?
Cisplatin 100 mg per meter square, carboplatin, and recently patented.
No, so mostly we are using cisplatin. Don't, if the examiner asks, please then say carboplatin. So why cisplatin and why not carboplatin? Carboplatin, although the side effects of carboplatin are lesser as compared to cisplatin, it requires higher temperature as compared to cisplatin to penetrate. Secondly, the penetration is less as compared to cisplatin. So how much does cisplatin penetrate?
Cisplatin, ma'am, 2.5 mm up to 2.
Yeah, 2 to 3 cell layers. So it penetrates 2 to 3 cell layers. That is why it is important that your CRS should be at least CC0 or CC1, less than 2.5 millimeter. Only if your gross residual disease is either 0 or less than 2.5 millimeter will your HIPEC be able to act. Because once your disease is more than 2.5 millimeter, the intraperitoneal or the HIPEC chemo will not be able to penetrate, because cisplatin, what we give, only penetrates 2 to 3 layers. So if your gross residual tumor deposit is more than 2.5 millimeter, HIPEC is of no value. So you have to be so when your examiner asks, the foundation of your treatment is CRS. The foundation of your treatment is a cytoreductive surgery. HIPEC is only offered once you have achieved at least a CC0, or if not a CC0, a CC1, but not more than that. Okay. So what is the evidence we have in ovary as of now for HIPEC?
Yeah, Vandel et al. Man, from Dutch. HIPEC improves overall survival and progression-free survival.
Yeah, so this is basically, it's not called Vandreel et al. Vandreel et al. Is the author. The trial is called OV-HIPEC.
OV-HIPEC.
Okay. Yeah, so OV-HIPEC 1 trial, it was a trial by a group of Dutch authors, Vandreel et al., wherein they took patients of stage 3 ovarian cancers who had already taken 3 cycles of chemotherapy, and intraoperatively, after they had achieved an optimal cytoreduction to no gross residual, they divided intraoperatively, randomized them into receiving HIPEC or not receiving HIPEC. Okay, so the group which received HIPEC had a good survival advantage. The PFS improved by almost 4 months, and the overall survival after 5 years it is almost 14 months, 14 to 15 months. So this is the level 1 evidence we have for HIPEC, but this is in stage 3 ovarian cancers. And they also found out that the rates of grade 3 or grade 4 morbidity was not different in HIPEC group as compared to the non-HIPEC group, although the rates of forming stoma, divergent stoma, were higher in the HIPEC group. Okay. So do you know any other trials besides this? Besides the OV-HIPEC trial? Yeah. What else?
Spiliotis et al. Man, but they did trial.
Spiliotis et al. Is a randomized controlled trial including all this thing. Okay, and it is a heavily criticized trial.
Yes,
okay, it involves other organ systems also.
OV-HIPEC 2 is undergoing, but it is going in upfront setting, ma'am.
So have you heard of a Korean trial by Lim et al?
Yes, Lim et al. Yes, ma'am. Korean.
Yes. So this Korean trial, it included about 180 patients. The difference from Van Driel's trial was that this included patients of both stage 3 and stage 4, number one. Number two, it included patients who underwent both primary cytoreduction as well as interval cytoreduction. So they did not find any survival benefit between these groups. But when they did a subgroup analysis in the group which had undergone chemotherapy first, they did find a survival advantage of HIPEC. But again, this group was small. So this trial has been heterogeneity because it included both primary as well as interval group. Secondly, it included both the both your stage 3 as well as stage 4. So now the Dutch group is recruiting patients for another trial known as OV-HIPEC 2 trial, which will take patients of only stage 3 in an upfront setting. And then after intra-op cytoreduction, they will randomize into HIPEC versus no HIPEC. So that should help us clear whether the HIPEC actually has a role or not. Again, there are some few retrospective trials in recurrent settings also, but as of now, we don't have any RCT for the role of HIPEC in recurrent setting. Okay. So the examiner will ask you, should you offer HIPEC to your patients? What will your answer be?
There is a level 1 evidence when we are doing HIPEC after interval debulking surgery, ma'am. So I will prefer to use it after interval debulking surgery.
What are the practical disadvantages of HIPEC in a country like India?
Major, again, ma'am, it has several complications like intra-op, early post-op and late post-op complications.
Yeah, most importantly, it delays your onset of chemotherapy. Okay. Besides the prolonged ICU stay, with cisplatin, I'll tell you the doses myself. Okay, so Van Driel trial used 100 milligram per meter square, but it did not use it together. It used 50% in the first half hour, then 25% in the next half hour, and then 25% in the last half an hour. Okay. And traditionally the conventional regime had been 75 milligram per meter square for 60 minutes. There is another regime which uses 75 to 80 milligram per meter square for 90 minutes. The 100 milligram per meter square regime is for again 90 minutes, but it requires the use of renoprotective agents, which we are not using currently. So practically the disadvantage of HIPEC in a country like India is it is expensive and economically may not be feasible. B, it leads to delayed, increased ICU stay, increased hospital stay, increased chances of wound complications, increased chances of burst abdomens, okay, potentially delaying the onset of chemotherapy. As of now, we only have one level 1 evidence of HIPEC, and that is by the Van Driel's or the OV-HIPEC trial. But even then, the ESGO, the European Society of Gynecology, still maintains that HIPEC should not be offered as a routine. It should only be offered in a trial setting. Okay. So you can say all these disadvantages are there and what you are doing in your place as a protocol. Are you offering HIPEC or not? So if I was asked this question, who am I offering HIPEC to? I'm offering it only to stage 3 ovarian cancers post chemotherapy. I am not offering it in upfront setting because there is no level 1 evidence. As of now, I am not offering in stage 4 patients who have responded to chemotherapy because the LIM trial has not shown any significant benefits. Okay. So this is the only level 1 evidence we have, and that is for stage 3, not stage 4, and that too in an interval setting. But like I said, the European guidelines still maintain that it has not been shown dogmatically that HIPEC adds to any value, and if HIPEC is offered, it should be done in a trial setting. This is for theoretical this thing. But they will ask you what you are doing in your center, and you can tell that is okay, that is acceptable. Okay, now coming to relapse. Quickly tell me what is platinum sensitive, platinum resistant, and platinum refractory relapses.
Platinum sensitive relapse when the patient experience a relapse after 12 months of first line platinum based chemotherapy. Partially.
Is it 12 months or is it 6 months?
12 months for platinum sensitive and partial sensitive 6 to 12 months.
You don't use the word partial sensitive. Okay? Go by what your theory books are saying. Okay? As of now, partial sensitive is a term which is more used by What is the definition in your books?
Partial sensitive when the patient experience relapse between 6 months to 12 months after remission from the first line platinum based chemotherapy.
It is 6 months. It is 6 months. There is no theoretically there is nothing like partial sensitive. Okay, it is preferable is 12 months. We say partial sensitive because if a patient relapses at 9 months, the medical oncologists prefer not to challenge them again with paclitaxel. Okay, that is why they call it partial sensitive. But otherwise, theoretically, it is 6 months. What is platinum resistant and platinum refractory?
Yes, ma'am. Platinum resistant when the patient experience relapse within 6 months after obtaining remission, but platinum refractory when the patient has not obtained any failed to achieve remission or progresses during the chemotherapy.
During chemotherapy, correct. So obviously, if it is a platinum sensitive relapse, you re-challenge the patient with paclitaxel, and if it is a platinum resistant relapse, what chemotherapy agents can you use?
We can liposomal doxorubicin, pegylated liposomal doxorubicin or topotecan, trabectedin, and we can also add bevacizumab.
Okay. Bevacizumab baad mein aa gaya. Don't add this again. They are just talking about chemotherapy drugs. Don't add Bev to it. Okay. What is the role of secondary cytoreduction?
Yes, ma'am. There is a role of secondary cytoreduction if the patient has a limited disease. There is minimal ascites less than 500 ml. If the patient has good performance status, if completion cytoreduction.
What is this score? What is this called? What you are telling?
AGO score it is called as AGO score.
Yeah, so that is a score which is used by the desktop trial. Okay, when you are asked to talk about secondary cytoreduction, you should speak first about whom you would offer. You don't jump directly to the score. So you say, I would offer secondary cytoreduction to a patient who has had a disease-free interval of at least 12 months and presents with a good performance status with an oligometastatic disease which is optimally cytoreducible. Yes. Explaining that the patient will require chemotherapy even after secondary cytoreduction. These are the subgroup which you offer secondary cytoreduction for. Then they will ask you what are the trials, what is the AGO score. Then you say that this was the score which was designed in the desktop 1 trial which included performance status of the patient, ascites less than 500, and the performance of an optimal cytoreduction during upfront surgery. So the presence of all these 3 criteria was called a positive AGO score. When they did the desktop 2 trial, that was more of a validation trial, wherein they found that the patients who had a positive AGO score, 76% of them were likely to undergo optimal cytoreduction during secondary cytoreductive surgery. So what is desktop 3 and what is another trial during secondary cytoreduction which is shown contradictory results? First tell me what is desktop 3.
Desktop 3 is a phase 3 randomized control trial, ma'am, used for a secondary cytoreductive.
What has it found? What has it found?
There is increased PFS and OS, ma'am, statistically significant, but
yeah, it has found a survival benefit in patients who had a positive AGO score, which we have talked about. The survival benefit in non-gross residual disease was above 60 months after performing secondary cytoreduction versus about 40 months in patients who did not undergo secondary cytoreductive surgery. On the other hand, there is another American trial called GOG213. Yes, which has shown a contradictory result and has shown no benefit in doing a secondary cytoreductive surgery. Yes. So why is that? Why it has not shown? What could be one of the reasons why GOG213 did not show? Yeah.
Because desktop trial used stringent criteria and it also used adjuvant bevacizumab. But
adjuvant bev was used by 213, not by this thing. Oh. You're talking about GOG213.
Because the criteria was not stringent one in
yeah, okay, so the criteria was not stringent. One is that what failed to show any benefit.
Don't know, ma'am.
So this is the group which actually, so they both the surgery arm as well as the no surgery arm were again randomized to use of Bev or not. Okay, so they found again that both the groups, both the patients who underwent secondary cytoreduction as well as the patients who did not undergo cytoreduction were again randomized into receiving or not receiving bevacizumab. So this was an added prognosticating factor which precluded the actual role of secondary cytoreduction, because even patients who had undergone secondary cytoreduction, they were receiving BEV, and patients who had not undergone secondary cytoreduction, a group of them were also receiving BEV. So that is why that is one this thing that the potential benefit of secondary cytoreduction could have been mitigated by the use of BEV in GOG 213 trial. Okay, so this is it. Okay, now just briefly, I think more or less we are done. Just tell me briefly about 2-3 things we need to discuss. One is dose dense, the other is use of BEV and PARP inhibitors, and then we are done.
Okay.
So tell me a little about bevacizumab. Why are we
Bevacizumab-
routinely using it, or why are the medical oncologists now advising for the use of BEV, and what is actually the current evidence of use of bevacizumab?
In case of recurrent setting, we can use bevacizumab 15 mg.
Do you mean to say they are not being offered in upfront setting nowadays?
No, ma'am. They are offering, ma'am, based on there are.
They are offering.
Yes,
They are
ma'am.
offering, but the actual use of BEV is in patients who have undergone a suboptimal cytoreduction. Okay, the use of bevacizumab in neoadjuvant chemotherapy is controversial. Where BEV has found to be useful is A, in patients who have undergone a suboptimal cytoreduction, B, patients who have recurring ascites or pleural effusion. So what is BEV actually? What is it?
It is VEGF inhibitor, ma'am.
Okay, yeah, it's a VEGF. Yeah, correct. So it's a VEGF inhibitor. So what are, do you know the name of some trials which have shown the benefit of bevacizumab in ovarian cancer?
Yes, ma'am. In case of newly diagnosed cancer, there are studies like ICON 7 and GOG 218. And in case of platinum sensitive recurrence, there is OCEANS and GOG 213.
Correct. Very good.
In case of platinum resistant, there is Aurelia.
So why are we so concerned about the use of bevacizumab? Especially nowadays, they have started using it in neoadjuvant setting also. What are the complications of use of BEV?
It is associated with delayed wound healing, perforation, fistula, hypertension. All those complications are
thromboembolic events, proteinuria. So for us, the major cause of concern is anastomotic leaks and wound complications, intracutaneous fistulas. So where the medical oncologist for some reason has given bevacizumab in the neoadjuvant setting, we always tell them to omit it in the last chemo preceding the interval debulking surgery. So if a patient has received let us say 3 cycles of chemotherapy before interval cytoreduction, if the medical oncologist has given BEV in the first 2 cycles, we will ask them to not give bevacizumab in the last cycle. Okay, so as to decrease these chances of anastomotic leaks and wound complications during surgery. Okay, now tell us a little bit about PARP inhibitors.
PARP inhibitor is used in case of BRCA mutant ovarian cancer because it acts by synthetic lethality mechanism of action. What is synthetic lethality? It means that the PARP inhibitor will act in case of BRCA mutated patient.
Why?
Why? Because PARP enzyme is used for repair of DNA damage, especially single strand. So it will repair the single strand DNA damage. But if PARP inhibitor is used, the single stranded DNA break will not be repaired and it will be converted to double strand DNA break, which cannot be repaired in case of BRCA mutated patient. Had there been a normal BRCA, this double stranded DNA damage could be repaired, and so the patient, there would be no effect.
Yes. So patients who have BRCA mutated genes or patients who show deficiency of homologous recombination. Basically, these are tumor suppressor genes which are responsible for repair of double-stranded DNA breaks. So, because these are mutated, in any case, they are already lacking the repair of double-stranded DNA breaks. So, to this, if we also inhibit the single-stranded DNA repair by use of PARP inhibitors, it adds, and this is known as synthetic lethality. So, can you name some PARP inhibitors?
Yes, ma'am. Like olaparib, rucaparib, and niraparib, ma'am.
Okay. So, can you name a few trials, or just even one trial which has used PARP inhibitors?
Solo series, ma'am. Solo 1, Solo 2, Solo 3.
Yeah. So, tell us about Solo 1. What did it use and what did it find?
Solo series mainly looked upon progression-free survival.
Yeah. So, what did it use? Solo 1 trial used olaparib, 300 milligram twice daily in a maintenance setting. Okay. So, while Solo 2 has been used in a platinum-sensitive recurrent setting, Solo 1 was used as a maintenance setting after the completion of surgery and adjuvant chemotherapy. So, in patients who were found to have a genetic mutation of BRCA1, BRCA2, they found that the use of olaparib 300 milligram twice daily for a period of up to 2 years, that improved the progression-free survival. In fact, the progression-free survival after 5 years was almost, there was 4.5 years of disease-free interval. So, but olaparib also has its own side effects. What are the side effects?
Anemia, fatigue, thrombocytopenia.
Neutropenia, nausea, vomiting. Okay, so that can be dose limiting, and many times we find our patients who are not able to tolerate 300 milligram twice daily and have to be reduced. It has to be reduced to 200 milligram twice daily, and this is quite common in the Indian population. Okay. Chemotherapy. Okay. How do you give paclitaxel in your setup? Adjuvant or your adjuvant? Yeah.
Ma'am, the doses of paclitaxel is 175 milligram per meter square, and carboplatin is area under curve 4 to 6.
And this is given at what interval?
Every 3 weekly, ma'am.
So what is dose dense now?
Dose dense is when we give 60 to 80 milligram per meter square every weekly.
No, it is not 60 to 80, it is just 80. Okay. So weekly is when we are giving weekly paclitaxel 80 milligram per meter square. You are using this in breast regimes also. Okay. So paclitaxel is 80 milligram per meter square. Carboplatin can either be given 3 weekly or it can also be given weekly. Okay. AUC2. So the initial trial which was published was by the Japanese group, Japanese Gynecologic Oncology group, where they found that the use of dose-dense chemotherapy versus the use of conventional chemotherapy had better survival rates. It increased PFS and OS, but it had more myelotoxicity. So patients were more likely to get anemic, neutropenic. Okay. However, the other recent trials have not, shared the same results. Okay. So again, this is not required for you, but like there is GOG 262, which has not shown the same results as the Japanese group. So it might be that one factor could be that the population, the ethnicity where it was used, the Japanese used it in the Japanese population, it has not been replicated in the Caucasian group. Okay. So as of now, it has not shown significant advantage in non-Japanese trials. Okay. So just let me check if we have covered everything. Just give me a second. In case you have any questions, you can please put them forth. And someone can write questions in the chat box, and Ved Prakash, you can just read them out to me in case someone has a doubt. I think so. Yeah. Role of no, absolutely none. Okay. Any case which is upfront operable should not undergo biopsy. Absolutely contraindicated because you run the risk of upstaging the disease. If the disease is early and upfront operable, you go ahead open the abdomen, remove the mass and send it for section. If it is an advanced Ca ovary, if you're talking about that, an advanced Ca ovary where you want to do a biopsy, in that case, normally the role is very limited. In case, the patient has a very atypical presentation where you want to rule out, some other histology, which is not a Ca ovary, you're trying to rule out some other histology, there it may help. Okay. Otherwise, in most of these cases where the disease is advanced, we proceed with a diagnostic laparoscopy. We assess the operability. In case there is a doubt, we take a biopsy, send it for frozen section and go ahead. But otherwise, in case in an ovarian Ca where you don't really have a doubt about the primary, in advanced Ca ovary, the role of biopsy is actually limited. It is only in cases where you chemotherapy that you will require a biopsy. Yeah, what else? Where is the chat box? I'm sorry, I cannot read it.
Okay, ma'am. A role of surgery in stage 4, ma'am.
Role of surgery in stage 4. So if it is if it is stage 4, if it is intraparenchymal liver and intraparenchymal lung mets and positive pleural cytology, we will go for chemotherapy first. If there is a good response to chemotherapy, then we will do surgery. Okay, this is not like stage 4 of other cancers wherein you declare the patient palliative. The only difference is that in case of intraparenchymal mets, in case of mediastinal or the presence of supraclav nodes or any disease outside the abdomen, you first go for chemotherapy, you assess the response, you go for surgery.
Follow up of same question, ma'am. Is liver resection advisable if there was parenchymal liver metastasis?
No, not upfront. Not upfront.
After chemo?
In case after chemotherapy, if that intraparenchymal disease is still there, at most you can do a biopsy. If it is still positive, then it is not recommended because it will not add to any survival.
Okay, ma'am.
Is there any role of biopsy in borderline ovarian? Why would you want to do a biopsy in a borderline ovarian? So borderline ovarian cancers and low-grade ovarian cancers, the best treatment is surgery. These tumors do not respond to chemotherapy. Sometimes they may respond to hormonal therapy, but even if a low-grade serous or a borderline ovarian cancer is advanced, you will go for an upfront surgery. One question is repeatedly coming, if frozen is negative. I don't understand this question. Frozen is negative for what? Can the person who's writing this question elaborate?
Evidence for 6 cycles for chemo. There is an ICON-1 study. ICON-1 study is there.
So basically there is Action Icon trial. Basically Action and Icon only said that whether in early ovarian cancers, A, you keep that group under observation, B, you give it chemotherapy. So the group which received chemotherapy had better survival rates. So Action and Icon only tell you whether the chemotherapy should be given or not. The evidence for 3 versus 6 cycles of chemotherapy is GOG 157. There they found that in early ovarian cancers, they divided one group which received 3 cycles of adjuvant and another group which received 6 cycles. They did not find any difference in survival between these two groups, and rather the group which received 6 cycles of chemotherapy had more side effects. But the results of this trial have not been incorporated into clinical practice. So you should not go with this idea in your mind that trial is there, so I will offer the patient only 3 cycles. As of now, all universal guidelines recommend 6 cycles of chemo. Yes, what was that question? Can you tell me?
Ma'am, in advanced ovary, if you send for frozen, so if it comes negative, what is the plan next? Like in the advanced ovary, your plan for primary cytoreduction. So
biopsy.
Your frozen comes out to be negative. Frozen of what? The deposit?
Yeah, like you have not taken any initial biopsy and you plan for frozen and proceed in the primary cytoreduction. Before primary cytoreduction, if frozen comes negative, what is the plan that time?
So it depends what you're talking about. And you've taken a deposit and you've taken one peritoneal deposit and you've sent it for frozen section and that comes out to be negative. So in that case, I would rather prefer the removal of the complete ovarian mass. So a complete, where the mass is there, the ovarian mass is there, it is better to take out the, if your deposit is showing negative, it's coming negative on frozen section, then it would be advisable to remove the complete ovarian mass and send it for frozen. It will be highly unlikely that, everything is coming out to be negative. Either it will come out to be cancerous or it will come out to be tuberculosis. Okay, it is highly unlikely that a deposit is negative and that you've removed that ovarian mass and that is also coming out to be negative. It has to come, something has to come. Okay.
Another question, ma'am. Base of bladder involvement, is it a contraindication for cytoreductive surgery?
Yes, essentially, because you would not want to, it is a contraindication for upfront surgery because ovary is not a histology where I would like to offer it. Because no matter what you do, 75 to 80% of these patients would come up with recurrence. So unlike say a cervical cancer or even an endometrial cancer, where we do consider exenteration, in ovary we consider exenteration only in a low grade disease or where the disease free interval has been long and that is the only site. Upfront, I would not like to consider a patient who has base of bladder involvement for upfront surgery because that may entail anterior exenteration. Having said that, the involvement of base of bladder is not so common in upfront ovary. What is more common is involvement of distal ureter. So your primary cytoreductions, even your interval cytoreductions for that matter, may require resection of terminal ureter and ureteric reimplantation, which is completely acceptable, and we have been doing it.
Yes, ma'am. Another question, supraclavicular lymph node positive, is there any role of surgery?
No, for you, no. Okay, what you do in practice later on is a different matter. In exam, if a supraclavicular lymph node is positive, yes, you have to give her chemotherapy first. And wherever a supraclavicular lymph node is positive, make sure you have an imaging of the chest because these patients, many of them have associated mediastinal and axillary lymph nodes positive as well. Okay, so for a patient of supraclav lymph node, please do not offer upfront surgery in exams. No.
Another question, ma'am. Any role of FNAC or biopsy in borderline ovarian masses, especially in intermediate risk?
Yeah, that's what I said. Why I would not want to do a biopsy. Okay. So if what can happen in this scenario is that if you have on imaging you have an ovarian mass and you have multiple peritoneal deposits, okay, and you are undecided whether this patient should go for surgery or should go for chemotherapy, okay. There, if you've done a biopsy and that is showing borderline or that is showing low grade serous, then you should go for surgery. Okay, in spite of the extensive disease burden, these are patients which will not respond that well to chemotherapy. So such patients, provided the general condition of the patient is good, these patients should come up for primary cytoreduction.
Yes, ma'am. Yeah. Is there any role of diagnostic thoracoscopy in patient with pleural effusion and negative for cytology?
Yes, that's a very good question actually. We are not routinely doing it, let me be very frank, but it has been done in trials and it has been done by few high volume centers in Europe and America. So what they do is, there they have, a larger criteria for including patients in primary cytoreduction. So a similar patient which I was talking about, say a patient who has ascites, who has peritoneal omental disease, okay, but performance status is good and the patient has mild pleural effusion. So many surgeons would like to start with thoracoscopy or VATS first and look inside the pleura. If there is no pleural disease, then they will proceed with primary cytoreduction. Okay. Secondly, if you were to apply VATS in an interval setting, so what happens is if the disease is stage 4, okay, and it has responded well to chemotherapy, so many surgeons would first do a VATS, look inside the pleural cavity, okay. If the pleural disease is still present, either they will abandon the procedure or they will, if it is cytoreducible, remove the pleura along with the abdominal compartment surgery, plus minus HIPEC, HIPOC. Okay, but this we are talking of high volume centers and more so in trial settings. Routinely, we are not doing it in clinical practice.
Another question, types of radical oophorectomy, that is Eisenkopf type 1, type 2, type 3, I think. Types of radical oophorectomy.
Types of radical what? Oophorectomy.
Yes, ma'am. There is Eisenkopf classification, ma'am. Type 1, type 2, type 3.
At least I am not using it. Sorry, I am not aware. Neither am I using it. I don't think any gynae oncologist was also using it. If surgeons have come up with this, you can tell me.
There is, ma'am, Eisenkopf classification, ma'am. I don't know details, ma'am, but there are 3 types: type 1, type 2, type 3.
Ma'am, basically, sorry, hello. Ma'am, basically, Sinkup et al. Had described type 1, 2, 3. Type 1 is basically what we do radical like THBSO.
Okay.
And type 2 is basically with the rectosigmoid resection. And type 3 is basically with the bladder, partial bladder resection and the ureter resection.
So I think, these are whatever has been described by Eisenkopf in his trial. Okay.
Yeah, ma'am.
So there is
Basically, I
something,
think all the time.
so these are terms which a particular author has used in his trial, and these are not routinely used in clinical practice. So I would not suggest you mention these things to your examiners because we are not using them clinically. So there are many criteria which are, so for clinical criteria for operability which are defined by different authors like Bristow, Fagotti, Nelson's. Okay, but not using them routinely clinically. These have been described by them in their papers. So what is not routinely there in clinical practice or guidelines, avoid using that. Okay. So Eisenkopf may have used it in his paper, but this is not a term which is either used routinely in clinical practice or in any of the clinical or universal guidelines.
Yes, ma'am. Role of adjuvant chemotherapy in borderline ovarian cancer.
No, so borderline ovarian cancers, unless the borderline ovarian cancer, only if it is showing invasion. Okay, so only if it is showing invasive implants or it is showing micropapillary pattern, only then chemotherapy is given. Although the role of chemotherapy is limited, we don't know how much it acts. But as of now, like I had said last time, we don't really have a different treatment for low-grade cancer versus a high-grade cancer. So any borderline ovarian cancer which is showing invasive implants is treated as a low-grade ovarian cancer. So low-grade ovarian cancer, as of now, we are offering the same as high-grade. We are offering chemotherapy, although we know that chemotherapy is not so useful in these patients. But more importantly, after the completion of chemotherapy, these patients are given hormonal therapy in the form of letrozole for at least 2 to 5 years.
Yes, ma'am. What are the situations in germ cell tumors where you avoid surgery completely? No indication of surgery in germ cell tumor. Yes, ma'am.
The only time where that is, no, there is, so in an upfront setting, if a young child is presenting with an adnexal mass.
BP regimen, can we avoid surgery, ma'am, if there is complete response?
So yeah, that is this. So in case BP is used in a new adjuvant setting, okay. In case it is used in a new adjuvant setting, normally we use 4 cycles. So if we operate first, then we give 4 cycles of BP. In case we are starting with new adjuvant, it is important to do a scan after 2 cycles and don't do it after 4 cycles. That will be similar to what, that you give all 6 cycles of chemotherapy of paclitaxel initially and then do. Okay. So if after 2 cycles, very rarely there is complete resolution, which is actually very rare, only then, okay, because most of the times we do try to remove the involved ovary. So in an upfront setting, even if we cannot achieve a complete cytoreduction, of course the aim is complete cytoreduction, but not at the cost of removing all organs in a 12 or 13-year-old for a tumor which is extremely. The plan is at least to remove the involved ovary. Okay, so it is very rare that we don't do any surgery upfront in germ cell tumor. Maybe in a case of recurrence, whence the role of secondary and tertiary cytoreduction in germ cell tumor is not so good. So in an upfront setting, I would still like to remove the involved organ. And if you are giving NACT, reassess after 2, not after 4.
And this has been answered. If supraclavicular lymph node disappear after NACT, should we go for CRS?
Yes, you do.
And all of students are thanking.
Yeah, okay, my pleasure.
Thank you, ma'am.
Okay. Yeah. Thank you. Take care and all the best to all of you.
Yes, ma'am. Thank you very much.